Hi, I'm Adam Spira. I'm a professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health, and I'm happy to be here today to talk to you about sleep, aging, and Alzheimer's disease. I'll be talking about sleep problems in the general population of older adults, then about sleep in older adults with Alzheimer's disease. Then we'll go to talking about sleep disturbance as a risk factor for Alzheimer's disease. And finally, we'll talk about sleep treatments and tips for better sleep. So just how common are sleep symptoms or sleep complaints among older adults? Well, in a study of over 9,000 community-dwelling older people with a mean age of 74, more than 80% reported having a symptom sometimes or most of the time. And when the investigators looked at the proportion of the sample who reported having a chronic symptom, that's a symptom that they had most of the time, approximately 60% had one or more chronic symptoms. So 20%, for example, approximately had trouble falling asleep, 30% difficulty with waking up during the night, and so on. So you can see that sleep-related problems are quite common among older people. So why are reports of sleep problems so common among older people? There are some changes in sleep that occur across the life course, even in the absence of any medical comorbidities. So these appear to be normal aging-related changes in sleep, not attributable to disease. And they include shortening of sleep, fragmentation of sleep by arousals from sleep, reductions in sleep efficiency, spending a smaller proportion of time in bed asleep, and declines in the amount of time spent in slow wave sleep, that's our deepest, most restorative sleep, and declines in REM sleep, or rapid eye movement sleep, during which most of our dreams occur. But we don't think that the prevalence, the super high prevalence of sleep-related complaints in older people is attributable to these normal age-related sleep changes. We actually think that they are due to other factors, including, perhaps most importantly, medical and psychiatric disorders and medications taken for those disorders. It's certainly not the rule, but people commonly develop chronic conditions as they go through life. And as we get older, we get more of those. And so we think that those can really affect sleep. So now I'd like to talk about sleep and Alzheimer's disease. So if you look at the sleep of people with Alzheimer's disease and compare it to the sleep of older people without Alzheimer's disease, you'll see differences that are similar to the changes in sleep that I described that happen across the life course. Specifically, compared to people without Alzheimer's disease, those who have it tend to have shorter and more fragmented sleep. They tend to have what we call lower sleep efficiency. They have reductions in their slow wave sleep and their REM sleep. And importantly, greater sleep fragmentation is associated with greater dementia severity. This is supported by animal studies. For example, a study by Rowe and colleagues in WashU in St. Louis showed that as amyloid plaques accumulate, the sleep-wake cycle is altered. And what this really, in combination with the changes in sleep that I just described that we see in Alzheimer's disease, findings like this really can lead to the conclusion that it's Alzheimer's disease-related brain changes that are contributing to sleep-wake disturbance, and that's why we see this link between sleep and Alzheimer's disease. In 2009, a seminal paper was published by Kang et al. In Dave Holtzman's group at WashU in St. Louis that showed if you sleep deprive an Alzheimer's disease mouse model, you actually get significantly more amyloid plaque in the brain within that organism. And in a study led by Tabuchi and colleagues in Mark Wu's lab at Johns Hopkins, it was shown that if you sleep deprive a Drosophila model of Alzheimer's disease, yes, there is a fruit fly model of Alzheimer's disease, you actually get greater amyloid deposition in the brain of the fruit fly model as well. These studies and others have provided a literature base that really supports an important potential causal role of sleep disturbance in the development of Alzheimer's disease. So although historically we really thought about links of sleep disturbance and Alzheimer's disease in this way, with the arrow going from Alzheimer's disease to sleep-wake disturbance, there are now questions that have been asked about, well, is it possible that sleep-wake disturbance is really contributing to Alzheimer's disease? And my colleagues and I did a study some time ago in collaboration with investigators at the National Institute on Aging Intramural Research Program,
where we studied 70 participants in the Baltimore Longitudinal Study of Aging
who had an average age of 76 and who provided self-report data about their sleep. And within 5 years of that, had a brain scan using Pittsburgh compound B PET, which is a tracer that binds to brain amyloid. We found that reports of shorter sleep duration were associated with greater amyloid deposition in the cortical distribution volume ratio, which is a metric of the amount of amyloid in the brain across many different regions. But we also found that shorter sleep duration was associated with greater amyloid in the precuneus, which is a region in which amyloid deposits early in the Alzheimer's disease course. We further found that poorer sleep quality, reports of greater restlessness in sleep, were associated with greater amyloid deposition in the precuneus. So if you look at the figure on the right, you'll see that there are 3 columns with colored images of brains. And moving from left to right, you're looking at people with increasingly short sleep duration. And you'll notice as you move from left to right that the colors become hotter. There are more reds, for example. And what that's showing is that shorter sleep duration is associated with greater amyloid deposition. Since that publication, many others have come out showing related findings. For example, this one by Weiner and colleagues showed in a sample of cognitively normal older adults who had polysomnography, that is the gold standard sleep measure, and were then followed for 4 years on average with PET scans, that those who spent a greater proportion of their slow wave activity, that's the slow wave activity that goes into the slow wave sleep I talked about, they tended to have less accumulation of amyloid over subsequent years. And those who had higher sleep efficiency, who spent a greater proportion of time in bed asleep, tended to have less amyloid decline over years as well. I was part of a study led by Christine Yaffe in which we looked at data from 298 women from the study of osteoporotic fractures who had a mean age of 82. And 35% of them had moderate to severe sleep disordered breathing, which is defined as an apnea-hypopnea index, or AHI, of 15 or greater. What we found was, compared to those who did not have sleep disordered breathing per that definition, those who did had almost double the odds of having mild cognitive impairment or dementia 5 years later. And because sleep disordered breathing has 2 primary consequences physiologically, those are sleep fragmentation and hypoxia or hypoxemia, which is low blood oxygen, we wanted to look at the relative contribution of those particular aspects of sleep disordered breathing to our outcomes. And what we really found was it seemed to be the hypoxemia that was driving the associations that we observed, and not the sleep fragmentation or sleep duration that might be shortened by sleep apnea. So in summary, the way that we currently think about links between sleep and Alzheimer's disease is really that there's a bidirectional link between the two. So I've been talking about the prevalence of sleep disorders. They are highly prevalent, and they are associated with poor cognitive outcomes. So you might be wondering, well, if I have a sleep disturbance, how can I treat that? I'm going to talk about a couple of different sleep-related treatments now. And the first is cognitive behavioral therapy for insomnia. So a few years ago, the American College of Physicians recommended cognitive behavioral therapy for insomnia, or CBTI, as the first-line treatment for chronic insomnia. CBTI is a non-drug approach, and that's important because several sleep aids that are sleep medications have been linked to poor cognitive outcomes in older people and other poor health outcomes, including falls and fractures. But CBTI is available through providers across the United States. As I mentioned previously, sleep disordered breathing is very common, and it's really characterized by decreases or cessations in airflow that happen repeatedly over the course of the night. And the two most commonly used treatments for sleep disorder breathing are continuous positive airway pressure, or CPAP, and mandibular advancement devices. CPAP refers to a therapy in which people wear a mask that pushes air into the airway to keep it open while they are asleep. And mandibular advancement devices are mouthpieces that people wear that move the jaw slightly forward to help keep the airway open. So as someone who works in a school of public health, I'm interested in those people who live in populations broadly and how we might improve their sleep health. And there are several approaches that we could take, or at least investigate. One that scientists have really been getting behind and advocating for is permanent standard time. Because when we switch to daylight savings time, we end up sending light signals to the brain too late in the day relative to when we want people to be sleeping. And part of the consequences is that we put people in a state of circadian misalignment when they're sleeping during a time that is not actually their biological night. Another important initiative starts much earlier in life, primarily in adolescence. A lot of the time, schools start quite early, and in adolescence, we see a circadian shift. I talked about earlier how with older adults, they have a circadian phase advance where they get sleepy earlier and go to bed earlier. The opposite is true in adolescence. When we are making them wake up early, they are not only getting less sleep because they're not allowed to sleep in, but they are made to go to school when their brains are supposed to be functioning optimally during their biological night. So that's another really important potential public health intervention to improve sleep. And we know that we sow the seeds for our later brain health much earlier in life than we see any manifestation of cognitive decline or dementia. Finally, the built environment is an important component of promoting sleep health. As an example, my colleagues and I are looking at cool roofs as a means of mitigating sleep disturbances in the population. What is a cool roof? Well, most roofs on homes are actually of a darker color, and that tends to absorb heat. And of course, roofs are very often right above bedrooms. And it's hard to sleep in the heat. And we know there's a significant scientific literature to indicate that high temperatures degrade sleep. And so there are also these cool roofs that are light reflecting roofs. And what they do is reduce the need for air conditioning and so on, and help save resources in terms of environmental resources. But we're interested in the extent to which that sort of a method or technology might be beneficial for sleep and downstream health outcomes. So I'd like to end by providing some tips for better sleep that I've gathered from websites hosted by the National Sleep Foundation, and you can see the links below. So to get better sleep, it's important to maintain rhythms, stable, regular rhythms. So get up at the same time every day. Also, get some natural light exposure in the morning. As we've discussed, bright light helps cue the brain to wake up. And exercise, which we also discussed, and eat meals at consistent times. Your bedroom should be dark, quiet, and a comfortable temperature, really a cool temperature. We know, as I mentioned a minute ago, that high temperature negatively affects sleep. Also, avoid alcohol in the evening and avoid caffeine after whatever time for you tends to disturb your sleep. The half-life of caffeine is 6 hours, so after 6 hours, half of it is still in your system. And don't go to bed hungry, and have a pre-sleep routine where you wind down by turning down lights and avoiding screens. And with that, I'd like to thank you for your attention. It's been a pleasure talking to you about sleep, aging, and Alzheimer's disease.